Hey everyone, we're just going to give it a couple of minutes while folks join the meeting, and then we will get started. Just give it one more minute or so. All right, everybody. Welcome. I'm Tom Walker. I'm the Executive Director at Encore Outpatient Services, a Caron and Maryland Addiction Recovery Center partnership. Thank you for joining us today for our webinar series, DMV Neighbors in Treatment and Recovery, a spotlight on local resources, programs, and expertise. Every week, we highlight a different provider in the DMV region to provide you with insights and resources you can utilize in your practice. Please note that these sessions are not eligible for continuing education credit. We will be conducting these sessions in a webinar format. All participant microphones will be muted. During the presentation, please utilize the Q&A feature to ask any questions you may have. We will have time for questions at the end of the presentation. This week, we welcome Alex Ribbentrop, who is a licensed clinical social worker, qualified supervisor in the state of Florida, EMDR trained clinician, and certified family trauma professional. Alex's clinical career has included work in for-profit and nonprofit settings, levels of care ranging from residential treatment to community-based mental health care, and time working with one of the top co-occurring treatment facilities in the country. In 2018, Alex founded Live Free Psychotherapy in Boca Raton, Florida, and has recently expanded the practice to include an additional location in Northern Virginia. Alex draws heavily on an academic background and philosophy to inform the therapeutic process and utilizes existential perspectives to support individuals in the development of personal meaning and value for their lives. Please welcome Alex Ribbentrop. Alex.
Hey, thank you so much, Tom. I think a quick thank you to start us off for sure to obviously to Tom and all the folks at Caron, at Encore, and at Maryland Addiction Recovery Center. I'm grateful to have a chance to talk about this topic, these topics, share some of my experience, hopefully share something with y'all that's of some value and some meaning. And so with that, we'll sort of get rolling. The title is a lot in and of itself. So each one of the terms in this title represent large fields of study in and of themselves. And the aim of this presentation is to primarily share some of my efforts and some of my experience in navigating what is meant by the terms trauma, intergenerational, personality, and also an effort to better understand what is actually going on with folks that present with substance use disorders or issues around addiction. Some of this really came about from, I guess, maybe earlier on in my career. I guess I'm still early on in my career, but even earlier on in my career, and navigating some of the treatment industry. And I think I was fortunate that I was able to connect with a lot of really good people early on that guided me in a lot of my sort of clinical understanding and training. This was definitely combined with a curiosity and a drive to better understand what it was, again, that was happening for somebody that was showing up in treatment. And really that drive was informed by a desire to be as helpful as possible. The more that I was involved in the sort of residential treatment setting, there were terms that would be used often. Co-occurring was a popular term, is a popular term. Treating underlying conditions, popular term. Trauma is, thrown around very, very often presently as a critical area of focus when doing treatment. And I found that I didn't have a cohesive understanding of what was meant by these terms, or at least it didn't feel satisfactory to me. And so, for example, when we talk about something like, right, we treat underlying causes, well, what exactly does that mean? Is depression an underlying cause of addiction? Is somebody depressed because of trauma? Is this more of a chemical imbalance that is separate from experience that somebody was sort of genetically predisposed to? And so very quickly you can go down a number of sort of rabbit holes in attempting to better understand what is meant by some of these terms. And so again, this curiosity and this interest led me basically to focus on the three segments of this presentation, being the ideas of intergenerational trauma, an effort to understand personality function through the lens of personality disorder traits and characteristics, and how that connects to presenting issues of substance use disorders. This again is combined with that drive to understand, you're sitting with somebody in a session, in a group, they continue to relapse, they continue to act in really insane self-destructive ways. What is going on fundamentally on sort of a human level for this person? And there's a ton of different theories to explain why some folks become addicted, what addiction is, what dependence is. Presentation is some of my effort to frame my understanding and the lens that I use in some of my treatment efforts. As we move forward and go to our first slide here, again, what is meant by the title of this discussion? And so a number of points as I've done some study and I've worked in the field, as I've ideally grown as a clinician, a number of points have become increasingly clear to me. One is that what shows up, the presenting issues per se, those issues that generally gain a diagnosis, are the proverbial tip of the iceberg. I don't know. I don't know if there's necessarily, I don't know if we could say that, what you see is what you get, period, end of story. I think generally what we see, and this is, this is well-known consideration, what we see are symptoms of underlying factors. And it's important, I believe that's an important lens to start off any treatment or any work with a client or family from. We want to take what they provide us. We want to meet a client where they are. However, we want to, or I want to remain curious, ongoing, right? I want to remain curious about what is actually happening underneath the surface for this person that they are not necessarily conscious of. It's a part of our job or my job to help bring conscious awareness to what has been unconscious. The symptoms that show up, right? These acute presentations, addiction, acting out behaviors, personality disorder traits and characteristics. These are symptoms of trauma in one way, shape, or form. And this is where our understanding of trauma can be more nuanced. And basically the symptoms, the acute presentations, are connected to an effort to regulate a dysregulated stress response system. So a person's, and this is again sort of a common understanding, addiction is in some form an effort to soothe, to self-soothe. It's a dependency issue. And it stems from a person attempting to regulate a dysregulated survival system. Our understanding of trauma needs to account for some of these instinctual elements that are evolved over hundreds of millions of years. Intergenerational, the idea of intergenerational comes into the mix because when we're talking about mechanisms that help us survive, even if they ultimately begin to backfire, we're talking about mechanisms that are passed down. So we learn how to function primarily within our core social systems. These are generally our family systems. And exposure to traumatized people is in and of itself traumatic. So if we have somebody that's experienced acute trauma 3 generations removed, right, they can very well pass along some of the maladaptive skills that they developed to cope with the initial trauma. And it may not be until 2 or 3 generations down the line that those skills become problematic and take on the form of something like an addiction. And the final point, I find this particularly interesting, and it might just be because of some of my kind of academic background. I like philosophy. I like to talk about theory. The topics we're talking about, family, human nature, will to survive, the will to learn how to lead better lives, or learn how to be better people. This is old stuff. This has been, these are topics that have been around for millennia, arguably in some form since the beginning of human civilization. And I think it's important to recognize that we're part of, in therapy and treatment and counseling, we're part of a rich intellectual history. Therapy, in the way that we perform it, is something that's relatively new. But a lot of the ideas and a lot of the practices that we draw upon are deeply connected to a very rich intellectual history. And I think this is an important fact to keep in mind because therapy is stigmatized. There's a negative stigma around people going to therapy. And I think the reality is we're continuing work that has been around for a very long time, helping to understand human nature, what this life is all about, and again, how we can better live it. The other piece that I think is interesting and unique to us is that there's an incredible amount of technological advancements currently that we are in a position to draw upon in I think some really meaningful ways. So breakthroughs in neuroscience, brain imagery, psychopharmacology even. I'd say even the adoption of mindfulness-based practices, yoga, elements like that put us in a great position to draw upon a lot of different information in order to provide the best quality care to our clients and their families and loved ones. So as I said before, we're part of a rich history here. The idea or the study of family, personality, interconnected nature of social systems and generations, this is nothing new. As humans, we seek patterns, and we seek patterns in trying to understand ourselves in the world. one of the earliest examples of this in reference to personality, I think this is just really sort of interesting, is the development of personality theory. So when we look at the DSM, and I think I have a slide in here somewhere that breaks that down. When we look at the DSM and we see these categorizations of personality traits and characteristics into specific disorders, that's an extension of something that's been going on for 2,500 years. Hippocrates, if anybody's familiar with the Hippocratic Oath, developed one of the first theories of personality, about 2,500 years ago. And this is basically a framework and a way of systematically understanding personality and behavior that's been expanded upon since that time in one form or another. Again, we see this very clearly, or I think we see this very clearly when we look at something like the DSM and current efforts to categorize and systematically understand presenting issues for folks. I also think, it's interesting to look at the relevance of family, especially in addiction treatment. We hear addiction is a family disease. Well, why is that? Well, people have a genetic predisposition. Okay, sure, like that can be a part of it. You look at twins, some twins are addicted, some aren't. Some siblings are addicted, some aren't. So the genetics plays a role. It doesn't tell the entire story. And I think that what we're seeing, a part of the reason, again, that addiction is a family disease is because family is important. And this is not something new. We've known this for a long time, and we can cite a long history of this to support that perspective. When you're working with a client and you're trying to engage the family, and they say, "Well, it's not my issue. Fix my kid." Look, it's not some groundbreaking piece of information that me as therapist Alex is saying it's important to have the family involved. Okay, we've known this for, again, thousands of years, and very simply, I find that fascinating, and I think it does support our efforts. A couple of examples of how family has been regarded as important in human development. We can look to Eastern traditions of Buddhism, Taoism, Confucianism. The idea of filial piety is of critical importance to the development of those ethical systems. If we look at Western tradition, religious tradition, we see in the Bible, individuals are introduced by who their ancestors were. Right? So we have Bill, the son of Bob, the son of Greg, etc. Right? So the importance of generational themes to inform what's going on with an individual, not new. We've known this to be important for a very long time. Again, I think a part of the importance of talking about the history, because I know it's a little bit off topic, I think it does destigmatize some of what we're doing in therapy, right? Therapeutic process is an effort to support others in living better, healthier lives. And that's a field of study and a part of different fields of study that have been around for a very, very long time. Therapy is not only for people that need to be institutionalized or people that are quote unquote crazy or any of the above. Therapy is very simply in some ways about navigating life and the fact that life can be inherently difficult. At this point, we'll move away from our historical context and address a little bit more directly some of these ideas in the title of the presentation. And starting off with personality disorder. For the sake of collective understanding and for the sake of effective communication, I do believe that it's important to have some kind of label, some kind of categorization, so that in general we all have an idea of what one another are talking about. I do think, this is still the case for something like mental disorder when describing personality disorders. I would say that we are at a place now where we could make a move in further recognizing that we're not talking about mental disorders versus physical disorders. We're talking about issues that have to do with a human being, and humans we are a collection of integrated systems. The mind and the body are not entirely separate. That's an old dichotomy. I think in our field we have a role in breaking that up a little bit. So I had mental disorder in quotation marks there. The other piece when we're talking about personality is the idea that personality disordered traits and characteristics are described as, or I describe them as, maladaptive. We're moving away from good qualities, bad qualities, and we're placing ourselves firmly. We're using the lens of survival to describe what we're seeing and to describe what's showing up, again, acutely or as acute presenting issues. And maladaptive, right, is used as well because it underlies the fact that we're talking about an entire system that in some ways is instinctually wired to do things in order to survive. Somebody is not necessarily acting out entirely of malice or poor intention. When we boil it down, we have a person that has inherited and or developed some mechanisms that they believe on some level keeps them safe. And when we're working with them and we're asking them to change, we're asking them to do away with the thing they've known and become familiar with that keeps them safe. This is not necessarily conscious, but it is powerful. And I think especially relevant when we're talking about personality disorders. Our next slide here is I think it's actually a nice kind of graphic of the current DSM breakdown of personality disorders. I generally hesitate to kind of hit somebody with a clear-cut personality disorder. I don't want to over-pathologize. I don't want to really sort of pathologize, period. A part of this presentation is a move away from pathology and, again, understanding problematic presenting issues as extensions of survival. We don't want to do entirely away with the fact that there are traits and characteristics that can be very much used to inform the treatment process and to inform our clinical understanding of an individual, what they may be struggling with, and that individual's family system. The other element that we want to be mindful of when talking about some of these traits and characteristics is that somebody showing up primarily with cluster C traits requires a different treatment approach compared to somebody showing up primarily with cluster B features. Well, both of these sets of traits and characteristics may have emerged from traumatic experience, we don't want to be using the same treatment approach for two different presentations. Additionally, the presentation of certain features can help us to identify other issues within the family system, right? So we know that there's some correspondence between cluster B features and caregivers. I think there's something like if a person has borderline features, right, or diagnosed borderline personality disorder, that's like the personality disorder du jour, there's a 5-time likelihood that their child will have those features. So if we have a client that, right, is showing up with some cluster B or borderline features, we have a decent indication that we're going to be seeing some of that, or maybe a lot of that, in the family system. If we don't treat the personality traits and characteristics, then we're not treating some of the primary defense mechanisms that have been activated and developed out of or in response to the traumatic experience. And a lot of times these are issues that underpin the more acute or easily identifiable issues like an anxiety, a depression, and addiction. A lot of times you have somebody come in, they say that they're anxious. Well, are they anxious because of, through and through a biochemical imbalance in their brain, or are they anxious because they've been using a set of coping strategies that are ineffective? And that's creating discord, discomfort, inconsistency in their life, which would be anxiety provoking, right? Another example of why the personality features are important. We see a lot of times the family correspondence in personality. If, for example, I take my borderline featured individual and I want to do some family work. Let's say I have mom who shares some of those borderline features, willing to engage. Dad is not. So something to consider is, do I bring mom in for a session, or do I say we need both parents unequivocally in the session, or we're not doing it? And the question really comes up because if we only have one parent join us, we may be unintentionally reinforcing some of the dynamics that contributed to our client's borderline features in the first place. So it's not a clear-cut, set-in-stone decision, but it is an example of where our recognition of how some of these features show up is important to informing our clinical judgment and our efforts. I don't think we need to do that by giving somebody a concrete label. I think some of the categorization is helpful, and I think that we can remain grounded in that trauma-informed, survival-based lens. Moving from personality disorders to a more thorough understanding, or maybe a different perspective on trauma. When I was in graduate school, trauma was, for me, I think was taught and primarily understood as associated with PTSD, right, an acute traumatic incident or incidents, and that PTSD diagnosis, a relatively clear-cut set of criteria. I think that, again, while there is relevance to acute trauma and a PTSD, diagnosis, that's insufficient to define or provide us with a definition of what trauma is. It doesn't effectively consider some of the implicit stressors that are involved, especially during early childhood, where a person's personality is really beginning to develop the most it will at any point in their life. Complex trauma, noted at the bottom of this slide, it is more implicit. It doesn't necessarily involve some acute issue or abuse. I like this definition: invasive interpersonal nature, right? So it can be quote unquote traumatic to have a primary caregiver or caregivers that are mentally ill, that have an addiction issue, that have traits and characteristics of personality issues. It can be stressful and it can activate our fight, flight, freeze system to be exposed to a caregiver that is inconsistent or doesn't recognize or teach boundaries. That can be a stressor. This is especially the case when we're talking about child development, right? The human being is far more dependent on their caregivers than any other species. We're born early. 9 months is a short period of time. It's a short gestational period. So we're born very, very early for our size and our brain development. We are, again, more dependent for a longer period of time than any other species. And so if our caregivers are inconsistent, right, and not in a malicious way, not in a bad way, it's close to impossible to be perfectly consistent as a parent, right? But any form of inconsistency can be a stressor. And so if there's chronic inconsistency, if there's chronic emotional reactivity, this can stimulate our stress response system over and over and over and over again. And if that stress response system is not deactivated, if our brain and our body, right, acting as an entire system, are not allowed to come down, then we stay at this heightened state. And this is where a lot of problematic issues can take hold very, very early on. The child knows on some level that their well-being is contingent on the well-being of their caregiver because of that degree of dependence. So the perception of the caregiver being unwell, again, inconsistent, etc., is a stressor. On some level, the child becomes quickly aware that they're not okay unless that caregiver is okay. That's a true statement for a child, right? The parent-child condition is a codependent one. That's something that I learned very clearly at one of my past jobs. A part of our development into healthy adults is moving away from that initial period of codependence that is so critical to our survival. An example, okay, of some of what I'm talking about is a child grows up with an alcoholic father, let's say. An alcoholic father gets angry. So early on, a child may, in response to the dad's anger, maybe that kid runs and hides. Maybe that kid acts out so that there's a distraction. Maybe that kid begins to try and people please, right? And try to soothe dad's anger. Maybe that kid tries to bring home straight A's because then dad wouldn't be so angry. So we have right there in this snapshot the potential emergence of a lot of problematic patterns early on. These are things that can come out as avoidance, acting out, may emerge as some antisocial cluster B traits, some perfectionism or people pleasing. Right now we're moving toward dependence. The additional element to that example is that we have a child then developing more awareness to the father's or the other person's emotions compared to their own. So the primary source of their emotional coping strategy, right, or the primary focus of their coping strategies is in regulating the parent's emotions. So we have the separation from one's own emotional experience, one's own affective experience, being geared toward a focus on the other person's. So when we have adults and we're talking about issues like codependence, this is where some of that stems from. And it's stemming from a child feeling compelled on some level to make sure the parent is okay, so they're okay, because it's a scary place for them to be if that's not the case. As noted earlier on in the presentation, one of the primary considerations when talking about trauma, understanding what is meant by trauma, is the recognition that trauma is connected to our survival system. And our survival system is made up of brain, body, nervous system integration that, again, has been around and evolving for hundreds of millions of years. Human evolution is about 7 million years. We have about, I think the number I saw was like 525 million years of evolution of this system in and of itself. And so this, again, it's important to be mindful of when we're talking about treatment and we're working with other people and we're having a hard time motivating change, for instance, is that a part of what we're trying to intervene upon is this well-tuned system that's been around for a really, really long time. And it doesn't take some enormous experience to create a response in our stress response system, right? Relatively small inconsistencies over time can be stressors. We can feel stressors to real stimuli, and we can feel stress to perceived stimuli, right? So even if things are all okay, if we feel, right, or we're believing that something is off, that fight or flight survival system will kick in. I think that actually I love this graphic here. It does a very, very good job of breaking down some of what actually does happen. And again, I think interesting and important to remember and recognize that, right, those presenting issues, that tip of the iceberg is rooted in this. So when somebody's acting out all over the place, yes, frustrating. Yes, we need to shift the expectation of that coping strategy. And we need to be mindful that that coping strategy exists because this system has never been deactivated. It's just always on, right? We're working with a person that is under or feels as though they're under constant stress or threat. And there is a biochemical nervous system response occurring all the time. I think a little bit later on, I talk about how trauma shows up for people in a variety of different ways. We're seeing increasingly that stress, trauma correlates heavily with issues of chronic pain, inflammation. It's not just things categorized as mental health issues. Expanding on that a little bit, I think in the previous slide it notes, it says cortisol and adrenaline released, the pituitary gland secretes adrenocorticotropic hormone. I should not have tried to pronounce that, but I think it went okay. And that's due to this, this system. And the graphic here is interesting as well. The graphic is is from a study where the academics, I guess, were looking to see correlations between a certain genotype, certain genetic makeup, and issues of OCD, autism spectrum disorder, PTSD, major depression, and substance use, to name, I think, a few. And so it's a graphic where these folks are looking at some of the genetic factors involved in trauma response. And I think attempting to identify whether or not there are some specific genetic markers and maybe even epigenetics at play, where genes are turned on and off based on experience. That's another field of study that's connected to this. And the jury, my understanding is the jury is still out as to whether epigenetics does play a role in trauma. So a lot more interesting research to be done on that. Again, sort of break down some of the ideas in the title. Talking about the idea of intergenerational or transgenerational. This is not brand new. We know that there's an interconnection between family systems and social systems, that our family systems influence our development, not just via genetic makeup, but also through experience and learning. And this is important, again, because we may have somebody presenting to us with a number of different issues, right? Depression, I don't know, cluster C issues, alcoholism. And we ask them about their background. They say, nothing major, right? Do you have trauma, any abuse, any significant events, any deaths? No, not really. So rather than sort of scratching our heads and going, right, that's weird. This is a great example of why the family history is of so much importance. So an example of this may be, and there have definitely been studies that validate this. Let's say you have parents that have survived something like a Holocaust or a civil war or a prolonged period of poverty, malnutrition. This is very much the case. You have parents that grow up and survive in these extremely traumatic living conditions. So these are folks that maybe, developed a way to deal with that level of chronic emotional stress. I mean, that's exposure to acute trauma over and over and over and over again. So these are folks that may have developed ways to disconnect, minimize, compartmentalize their emotional state. When these folks have kids of their own, without any malintention, without any bad intention, some of these coping mechanisms are going to be passed along. So when their child comes home from a bad day at school and says, boy, today was really tough, right? the parent may say, right, hey, it wasn't that bad. Nothing bad is intended there. They're trying to support their kid. But we may see that over time, that kid becomes less and less inclined to share about their bad day. And then we have a kid that has had a good life overall, went to good schools, parents are tough, hardworking people. But this kid has begun a pattern of internalizing their emotions. Maybe they didn't get as much practice as they needed in expressing their emotions. And over time, we have the emergence of something like a depression. We have the emergence of something like an alcoholism or an addiction in an effort to self-soothe, because some of those strategies weren't practiced earlier on. So we have this example of how experiences, even that's a intergenerational example, but even experiences generations removed can have that kind of trickle down effect. This is a great slide that does, I think, a wonderful job of highlighting how issues and experiences on a national level or a larger macro level can impact smaller systems from the family down to the individual. And this is another study that focuses specifically on that HPA axis I noted earlier. And again, they were looking at epigenetics and whether or not basically certain genes are turned on and off based on collective experiences and individual experiences. But if we break this down, does a really good job of highlighting how these traumatic events are interconnected and can be passed along through different levels of a society, a family, and individual interactions. So I want to be mindful of our time here. So I think next couple slides here, and I think this brings us essentially close to our finish. Reinforce and review some of the ways that the child can take on some of the stressors or emotional stress of primary caregivers and family systems early on. And these ideas connect again to the fact that the human child is incredibly dependent on the okayness of their caregiver in order to feel okay. Right? There's an interesting fact about, I think, the human eye is more easily readable than that of other animals, and part of the evolutionary explanation for that is that infants have bad eyesight. We're born early, so infants' eyesight is not developed, and so they need to be able to see the eyes of their caregiver more clearly. It's part of the reason we think, again, from an evolutionary perspective, that we hold our children close to our faces so that they can read our face. If that's inconsistent, if that face is changing, if that face looks scared, over time we're sending messages to a very young person about whether or not it's okay for them to feel okay. And so these, again, are some of the ways that personality disorders, substance use disorders, mental health issues may emerge. These are underlying, I think, some of the most underlying issues involved in our treatment efforts for folks. This is another, I got this from a white paper done by one of the writers was Vander Koch, who does, Body Keeps Score fame, and some other practitioners. A great article. I have the citation if anybody wants the slides, but really great example here of how far reaching the impact of trauma is. So it ranges from attachment to biologic implications. And we know more and more that issues like chronic fatigue, for example, may in fact be a person that has had a stress response for so long that it's sort of cut out. And so they've been operating at such a high level for such a long time that system has become fatigued. That fight or flight system has become fatigued and has just dropped. And so right now then you have a chronic fatigue issue. Same thing happens. We see similar things happening with issues like IBS, fibromyalgia, chronic pain, etc. And so when I review all this information, hopefully bring it together in some cohesive way, the therapeutic cliche of tell me about your childhood, tell me about your family is cliche for a reason. Wanting to know about early experiences is important. Having an understanding or attempting to understand formative childhood experiences and family systems is critical to informing effective clinical work. This is something that has been known, the importance of family, the importance of developmental milestones. This has been known for a long time, again, in reference to some of the historical context that we noted earlier on in the presentation. And when this intellectual history is combined with hundreds of millions of years of evolution in reference to our survival system, we end up with this unique lens, or I think unique lens, to view our clinical work and treatment of individuals and families. And so we have this bizarre mix then of nature and nurture. And we're working with people that are ever evolving, sometimes in adaptive ways, sometimes in maladaptive ways. And essentially, these are all efforts to navigate how to use what we have in the world with what we're met with in the world. And life is far from perfect. It involves pain, it involves hurt, and we're influenced by this. So just like you get a cut, sometimes a cut heals, sometimes it leaves a scar. Same thing happens when we're talking about experiences and impact on psychological makeup or personality makeup. And so this idea of complex trauma and more acute presenting issues emerge from our efforts to regulate a survival system when we may not have been provided with some of the tools necessary to regulate it ourselves in healthy ways, or we were exposed to enough that was overwhelming to us, where we felt we had to come up with something different. Again, a lot of this is implicit. A lot of times somebody is not going to readily recognize that these issues are significant. And that's a part of our work, is in bringing conscious awareness to some of these unconscious elements. And ideally, by doing that, removing some barriers to change. So by increasing awareness that some of these things are factors, ideally we're providing a person with a greater chance to make different choices about how they want to respond and live their lives. When working with individuals and families, the use of this sort of integrative lens, I believe, helps to decrease our stigma by placing therapy and treatment as part of a broader human effort to live healthier, better lives. And understanding that a lot of what we see is not because somebody is bad, it's not because somebody's crazy, it's not because somebody's broken. It is because somebody is operating out of a system that's very, very old and trying to keep themselves safe. It's just that these safety mechanisms have begun to backfire. And it's a part of our work to help reroute some of these systems. I hope that, I know it's a lot of different directions, but I do hope that some of this information has been perhaps new, of some interest, and I hope of some help as we continue our work in helping individuals and families in their lives. So thank you again very much for the opportunity to speak. I greatly appreciate it. Thank you.
Thank you, Alex. I got the sense with your topic and talking to you before this presentation that we'd kind of only be able to bounce across the surface. So we might want to look at maybe a part 2 and digging a little deeper.
Oh, interesting. Yeah. Yeah, I'd be happy to.
We can talk about that.
Yeah, I'd be happy to. I'd love to. I mean, just there's so much information. That's the hardest thing about it is I feel like I go in 5 million different directions. But
yeah, no, there's a million different directions to go in, and there's a lot of folks, you know, that attended today that I know have a similar area of focus or doing this work in their practice as well. So I think being able to connect and, you know, expand on what's working and who you're seeing, and maybe even sectioning down and really looking at some of these points, I think it'd be great. We can talk about that offline.
absolutely.
Thank you for coming out while we have you and kind of closing things out.
Yeah.
You're in Florida, you're moving to Virginia, you're licensed in both, you have a practice that is open and functioning in both places. I think the virtual platform lends to a lot of flexibility there. Tell us about your practice and tell us about the best way to reach you.
Oh, sure. Let's see. So, yeah, as you noted, I've been here in Florida since 2014, and have been in practice since December 2018, and recently licensed in Virginia with plans to be back in that area shortly in August. Actually, I'm working entirely via telehealth at this point. And anybody that might want to reach me is free to, I think probably the easiest way is Google my name, Alex Ribbentrop. I also have a website that you will find if you Google me. And then the best contact number for anybody interested in reaching out, shoot a text or give a call, is 561-507-1133. Sending a text message is usually the easiest way for folks to get in touch with me because I'm able to check it between sessions. Yeah, I'm excited to get back to Virginia too. That's where my wife and I are from. She and I both went to George Mason School of Social Work for our graduate degrees. I did a lot of my early social service work in the area, so it's cool to be able to do this talk and get back to a place that was so kind of formative in directing me in this field to begin with.
We're looking forward to having you here more locally as well.
Thank you. Yeah.
There were a couple requests for slides, as well as I think someone was asking about citations on some of the slides to go back into the kind of white papers, and there you go. So we will, with your blessings, send that information out to the participants with your contact information as well.
Oh yeah, that's great. Okay. Yeah.
That's wonderful. Alex, thanks again so much. We'll circle back and talk about a part 2. I really appreciate you taking the time to put this together and present to everybody. For everyone else that joined us, thank you very much. Join us next week, same day, same time, as we welcome Laura Goldstein from Montgomery County Counseling Center, who will share on the topic of motivating parents to practice validation skills. Registration is now open for this webinar. Watch your email for details. Also, as we post, new topics, in the coming months, those will be available for registration following the same link. In the meantime, please feel free to reach out to myself here at Encore Outpatient Services, to Mallory Schwartzman at Maryland Addiction Recovery Center, Jess Ayer, who represents Caron Treatment Centers in Maryland, and James Fletcher, who represents Caron Treatment Centers in Washington, D.C. and Virginia. Have a wonderful rest of your day and rest of your week, everyone. Take care.